So good afternoon, full-time PET team. This is the last of the PET talk sessions. So there's a little tear in my eye, there's a little lump in my throat, and I have a slightly wobbly bottom lip as we come to the end of the PET teaching for the first year. Dun, dun, dun. We got the CAA next Thursday. Okay, so you should be prepping for that. But before that, we need to prepare for the VIVA practice session. And the VIVA practice session is going to be super important because that's where you can have a go at the entire VIVA format. And that will be done next week. So looking forward to that. Let me just see when that is on your diary, guys. So that's going to be Tuesday and Wednesday of next week. So Tuesday and Wednesday of next week is what I want you to prepare for. So you're going to prepare two case studies, there are two case studies to prepare, but you're only going to do one of them. You're either going to do Justin or Cedric. You're not going to do both. So both of those case studies can be found in the VIVA practice session, the folder for the practical. Not only do you have the case study, but you have the questions that go along with it. There's three types of question that will be very similar to the format as well. Okay, just give me a yes in the chat if you've already managed to see those. Just give me a yes in the chat if you've already seen them. Yeah. Okay, so a few of you preparing for that. Now, it's super important that you prepare for that session before the practical, because you go straight into the practical and you have to have done the preparation for it. If you haven't done the preparation for it, there's no point in turning up because everyone will be doing that exam. Okay, just give me a Y in the chat that you understand that you must prepare either Justin or Cedric for next week. Yeah. Okay, that's super important that we do that because there'll be no time in the session. No time in the session to do that. Okay, so without further ado, we will crack on. So for the last time, we tell you that the physio profession is about human anatomy and physiology, human movement and function, maximizing wellness and our potential, our human potential, minimizing disease and injury, and solving real world problems. And we've got lots of real world problems at the moment. I'm sure that those problems will only grow. So there's never been a better time to be a physio. Your country and indeed the world needs you. So what are we going to learn in this session? We're going to be applying those principles of exercise therapy in the exam format, which is the VIVA practice. So there's two parts to this. There's the computer assisted assessment, and then there's the VIVA. And the VIVA is really that half hour of where we see what you're made of effectively. You'll be able to demonstrate that you can put theory into practice and be able to prescribe exercise safely to your patients, remembering that exercise prescription is our most evidenced form of therapy. So it's super important that we prescribe exercises correctly. So for the VIVA, what I'll be doing is I'll be discussing the practice VIVA and the real VIVA sort of interchangeably. So in the actual VIVA, you'll get one of four options, and you've got to revise all four because you don't know which one you're going to get. So there's three individual case studies. Okay, three individual case studies, and then there's a total of four case studies, and the fourth being the cardiac rehab group exercise case study. And you're allowed to take one sheet of A4 paper in with you. Okay, so I have seen people take very few notes in with them or loads of notes in with them. But the great thing is that you can refer to your notes entirely throughout the entire exam, which is really helpful. Give me a thumbs up in the chat if that's a helpful thing for you to do. Take a piece of A4 into the exam. Yeah, I think so. I would agree. Yeah, super helpful. Okay, so you're going to get the case studies. What are the names of some of the individual case studies? What are the names of some of the individual case studies? There's three names. We got Megan. Yeah, Megan strangely got that. Yeah, so we've got Megan. What are the other case studies? What are the names? We've got Martin. Yeah. And lastly, we've got Albert. Okay, good, good, good. And then for the cardiac rehab case study, we've got 5 different names. Give me some of the names from the cardiac rehab study, please. We got Jeffrey, we got Peter, we got Ahmed, yeah, we got John, Jeffrey, and we've got Natalia. Well done there, Mary. Okay, yeah, so we've got those 5 cases. So it means that it suggests to me that you've at least had a look. Remember, you'd have had these case studies. You've already had them a month. The exam is in a month's time. So you have 2 months with these case studies. That's bags of time for you to get your head round and know that case study inside out, back to front, upside down. Okay, so what we want you to prepare, and this is prepare for the real Viva and also the practice Viva, is the problem list. So your patients come to you with problems, lots of problems, and you as the physio are a problem solver. That's what we do. We're problem solvers. And when through our problems, we then formulate some short-term goals and some long-term goals. And then we've got to think about the relevant outcome measure. Okay, why have we got to think about outcome measures, guys? Because what's my saying with outcome measures? If you're not, come on, if you're not something, something. Yes, David was there, then Holly, then Magali, then Thomas, then Megan, then Alex. Yeah, okay, fantastic. Yeah, if you're not assessing, you're guessing. Yeah, or what gets measured gets managed. Yeah, okay. Measuring, you're guessing. That's not quite right. Okay, that's like mixing your metaphors. That's like you're not the sharpest tool in the greenhouse. Doesn't make sense. Okay, so we've also got, let me go back, Rehab Guru and PhysiTrack are going to give you all those, exercises that you need. There's loads of different exercises on those software, prescription things, and obviously telehealth and exercise prescription is the future. You need to get into that. That's what I've been doing in my private practice, so that's important. Right, so this is the structure of the exam, and this will be the same when you do the mock Viva as well. You will have 5 minutes where you will be given the question. Yeah. Do we need to provide evidence, Rehab Guru evidence? No, you don't. Okay, I'd love the fact you're talking about providing evidence, James, but you don't need to. Okay, so we're going to go into the exam. We've got 5 minutes to prepare. You'll be given the case study. Okay, so you'll be given, for the mock Viva, you're doing either Justin or Cedric. You're not doing both. You only need to revise one, Justin or Cedric. Then you'll have 5 minutes to think about that particular case study, and you'll be given the questions. The questions might be on strength, on range of movement, on balance, or some of the latter stage components of fitness, or depending on whether they're early or late stage. Then you're going to go into the exam and you're going to talk about the problems. I want a minimum of 5 problems, and then a minimum of 3 short-term goals and a minimum of 3 long-term goals. Yeah? So that is 5 minutes of discussion. Then you're going to be doing the practice side of things. So you're going to be doing the hands-on practical, and you'll be prescribing exercise. You're going to be giving your model some exercises. And remember, the way that we deliver exercise is the acronym IDEA. So we introduce the exercise. Yeah, we talk about it and why we're going to do it. Then we demonstrate it. As the physios, we demonstrate it. So the patient can use their visual learning. Then we get the patient to execute the exercise. And then the A is for adjustment. The patient never does the exercise correctly, so we need to adjust them. So use that acronym IDEA to talk about the exercises you prescribe. You're going to be doing 2 exercises probably with a progression and a regression of both. Then you're also going to be using an outcome measure that must be appropriate to what you want to measure. Okay, so it's no good measuring balance if I've asked you to do strength. Yeah, it's no good doing 1 repetition max, okay, for strength if I've asked you to do balance. Okay, so it's really important that you get the outcome measure right. And the outcome measure, again, you need to introduce it, demonstrate it, execute it, and adjust it. So it's the same format whenever you're doing hands-on. Just remember the 5 pillars of stability. Get hands-on with your patient. We're hands-on therapists. You're in PPE, so you're safe. Next, we're going to go on to the next stage, which is the discussion of the principles of exercise therapy. So why did you prescribe those particular exercises that you gave your patient? And then any safety points that we're thinking about, any contraindications, and you can fail on safety. So, you know, just make sure that you are safe, particularly when you're doing the group exercise, because group exercise with cardiac rehab, and there's lots of contraindications for people with poorly hearts before they do exercise. And then finally, there will be the quick fire round where we can ask you anything we like in the entire PET syllabus in the last 5 minutes. And this is to check your general overall knowledge about what's going on. Okay, give me a thumbs up in the chat if you are happy with the exam format. Thumbs up in the chat, please, if you're happy with that exam format. Good. Yeah. Okay. Fantastic. So we're all clear on that. So let's deep dive. IDEA stands for introduce, demonstrate, execute, and then adjust. Yeah, and we talked about that on previous videos, Harriet, as well. So what you want to do, go back and have a look at some of the videos when we talked about introducing exercise. Okay, and we're going to come on to this in a second, Beth. So don't worry. I'll go through it all seamlessly for you. Okay, so Beth, it's going to be 5 problems and 3 goals, 3 short-term, 3 long-term. We'll come on to that in a second. So remember the components of fitness. We've got a picture of Stuart there, bottom right-hand corner. That was on his summer holidays 2 years ago now. So looking in shape there. Well, thank you for letting us do that, Stuart. And we've got our physical components of fitness, and then we've got our motor components of fitness. Yeah, important that we differentiate between those 2 components of fitness. Generally, flexibility and strength are things that we want early on in terms of the physical. In terms of the motor, we want balance early on. And then in the later stages of rehab, we're going to want things like speed, agility, power, and coordination always happens throughout. Okay, moving on. So we come up with our problem list. So here's an example of our problem list in our patient. The patient might be lacking range of movement. Yeah, it looks like it's you, Mary, and not me. It was me earlier on. It's now you, I think. Okay, but it's being recorded, so don't worry. Okay, so another one might be strength deficit. They might be a 4 on the Oxford scale rather than a 5. They might have insufficient balance and proprioception, so that can be measured in a number of ways. And they might also have some coordination issues. So there's just some problem lists. We might be thinking about the functional tasks. Okay, so you know they want to get back to a certain sport or a certain activity. We could be thinking that problem list is they might be lonely if they're living on their own, or they might be unable to work because they're self-employed, and the list goes on. So it gives you an example of some of the problems that we might have. So we've got to think about the activities of daily living. It will be based on the patient's problems. Yeah, based on the patient's problems. We're solving the patient's problems for them, Grace. Hopefully that makes sense. Okay, so we've got various positions. Getting out of bed, okay, sitting to stand, okay, standing to walk, okay, walking to run, okay, and running to jumping. So there's going to be lots of things that we need to do. Things like toileting, feeding, dressing, transfers, all these things that we need to think about for our patients with significant disability. But we've not included them in the PET case studies, apart from potentially Albert. Most of the people are independent, so it's easier for you to prescribe exercises to them. So we've got to think about our phases of healing. Okay, so when our patient comes to us, they'll be in different phases of healing. We might see the patient very early on. Okay, so in my case, I might be working pitch side, okay, and I might actually run onto the pitch and treat that particular player, and then I might treat that player all the way through their rehabilitation journey, okay, until they pop out the other side and start playing sport again. Does that make sense? We might see them, so that would be acute management, then we might have, or early stage management, then we might have subacute, okay, sort of six to 8 weeks, and then anything sort of beyond 3 months or 12 weeks is what we consider chronic. So if your pain and your disability consists of over 3 months, over 12 weeks, that's what we call chronic problems, and that would mean you do late stage. Okay, now for something like a significant operation where we need to get an individual back to sport, the late stage might be much further down the line. It might be sort of 6 months and beyond. It very much depends on what's going on, and what you might want to do is have a look at some rehabilitation protocols and NICE guidelines, for example. So healing times are important. Okay, so we do this we formulate a problem list from our needs analysis. So what 2 factors, type in the chat, do we need to think about when we think about needs analysis, guys? Needs analysis. The individual and the task. Well done, Megan. Yeah. Magali, Jade. Yeah, Mo. Okay, Anthony, well done. Individual and the task. They're the 2 things. Okay, so what individual, what task do they need to do? And then if we think about acute stage rehab, okay, what does, imagine you've injured your knee, your ankle, your hip. What are the 3 components of fitness that we really need to focus on early stage rehab, acute stage rehab? What components is early stage? Strength, yes. Flexibility, yes. Yeah, James saying balance as well. Yeah, so yeah, good. Flexibility, strength, and balance. Alex P, you're the only one that got them all. Well done. Okay, so that's good stuff. So remember, acute stage stuff, we want range of movement, flexibility, we want strength, and then we also want balance and proprioception and all those good stuff. Okay, so here is an example of some short-term goals. Short-term goals might be to restore range of movement so that left equals right. Yeah? It might be if someone's just had a significant operation on their knee, it might be that they just get a static quads contraction for 6 seconds and they repeat that 6 times. So that would be really super acute day 1 strength training. Okay, so that might be a short-term goal, very realistically. Okay, our long-term goals would be to get back to the desired function. Running, football, rugby, okay, I don't know, climbing the stairs, whatever they need to do. And we've also got to think about how do they maintain fitness while they're injured, training around the injury, okay, so that they can get fitter despite their injury. And then long-term goals might be return to work, okay, any number of things, okay, but we've got to think about early stage and late stage rehab as 2 separate entities that are part of the same continuum. Give me a thumbs up in the chat if you're happy with early and late stage being part of the same continuum. So just Rebecca and Anthony there. Fair enough. Okay, at least there was 2 of you. Okay, so what we've got, Holly, is we've got early stage rehab and late stage rehab. And if you have a look here, okay, so we've got early stage rehab, then we've got this kind of mid stage, subacute stage, and then we've got end stage rehabilitation. Yeah, so this is an example from sports. Okay, so what exercises are they going to need very early on? Okay, what exercises do we do in the mid stages? Okay, mid stages, and then what exercises do we do in late stage rehabilitation? Yeah, so this gives us an example of that sort of stuff. Yeah, okay, early, mid, and late stage rehab. Yeah, we've been through all this in our exercise rehabilitation planning lecture 12 PET. So you need to go back to those ebooks and have a look so you can fill in the gaps in your knowledge there. Okay, then we've got our 6-stage exercise progression model. So the first stage, we isolate and we educate. That might be the static quads contraction, for example. Yeah. Then we're going to add some resistance. That might be gravity resistance, might be a resistance band, might be a bit of weight. Then we're going to add the functional pattern at level 1. Then we're going to add the functional pattern at level 1 with some resistance. Then we're going to work on some stuff from core to extremity. Then we're going to layer the different components of fitness. Okay, so that might be a lunge with a twist, and a throw, for example. Okay, I've done this 6-stage progression model to death. Remember, we can go up and down the progression model so that we can also regress this as well. Quick thumbs up in the chat if you're happy with this. Quick thumbs up in the chat. Yeah, we've done this model to death. Okay, yeah, good, fantastic. So look on Rehab Guru or PhysiTrax or any exercise prescription software that's available to you. There is so much there. So one of the criticisms in PET is, oh, I didn't get taught any specific exercises. And that is on purpose. We don't teach you recipes. We teach you clinical reasoning, okay, which is uncomfortable at first. So what happens is you use the exercise prescription software and it will give you access to thousands of exercises. I don't have time to teach you this sort of recipe-based approach, okay? You must find your own way. I can show you the path, but you must find the way. So it's important for you to look at Rehab Guru, PhysiTrax. There are thousands of exercises out there. You can find all the solutions on that exercise prescription software to all the case studies. Yeah, so there is no excuse to get the exercises that are incorrect because the exercise prescription software will tell you. I'm giving you the solution because I am that kind, guys. Okay, I'm good to you. You just need to apply it. Okay, so we've got making sure that we understand the principles of exercise therapy. So we've got to understand the period of time that will be required for our patient to adapt to the motor and the physical skills that they require. We've got to make sure that the task is specific to what they need based on a needs analysis. We're going to have to progress and regress accordingly. Yep, we're going to need to create overload. So we're going to need that drive principle. We're going to have to appreciate that if they don't continue exercising, they will get the reverse of what they want. So if you stop exercising, you stop getting the benefits. We need enough time out between our sets and reps and also between our days of exercise as well. We've got to create some sort of behavioral change. Okay, most people don't do their exercise. It's rare and disciplined person that exercises every day. Okay, and we've got to think about the individual. Are they stressed? Are they demotivated? What's their mental health like? Okay, what's their age like? What's their training history? You are treating an individual, not just a patient with a knee problem. We've also got to think about how they integrate that into their lifestyle. And we've also then got to think about the law of diminishing returns. That means that better takes longer. When we first rehab people, they make massive gains and improvement. And then eventually they hit what we call the rehabilitation plateau. That means that in order for them to get better, that would require a huge amount of effort. So we tend to just say, well, that's going to be, we've reached our rehab plateau, law of diminishing returns, we just leave it there and maintain them. And then, of course, we give back the responsibility to the patient. Ultimately, it's their body and their choice. Okay, we can't do their exercises for them. If they've made poor choices, we can help them to make better choices. And that really is what being a physio is all about. Okay, so we've got things like strength training. and muscular endurance training. And we've got the bodybuilder hypertrophy training that we're not interested in. Okay, so that I haven't included rest on this one. So if we're looking at strength training someone, which is 85% of their 1 repetition max, they can't do any more than 6 repetitions because the weight is that heavy. They're doing between 2 and 6 sets. How much rest in minutes would we have between sets if we're strength training? 2 to 4 minutes again? Yeah. 2 minutes? Yeah. Okay, 2 minutes is a minimum. Okay, and you might actually have up to 5 minutes. Okay, not 10, Will, but 5 minutes. Okay, so even Eddie Hall, UK's strongest man, only has 5 minutes between sets, and that's because he's lifting so much weight. It takes 5 minutes for his body to recover from that. Now, if we were doing muscular endurance, how much, which is 67% of our 1 repetition max, going to be roughly 12 to 20 reps. Yeah, Mo is there with 30 seconds. Boom, David's there. Yeah. Okay, anything between 30 seconds and a minute if we're working muscular endurance. Completely different energy system. Yeah. And just for giggles, okay, if we are doing hypertrophy, how many sets, how many reps, and how much rest? It's something sets of something with some whatever rest. It's the typical 3 sets of 10, yes. How much rest in between? How much rest in between? If we're bodybuilding. No. Yes, Dave's right. Okay, so it's roughly about 90 seconds recovery in between. Well done, David. Great stuff. Okay, don't worry about power. Okay, power would be things like doing some jumping exercises or some Olympic lifting. Okay, so a single moment might be as far as you can. So jump like a standing broad jump. Jump as far as you can, or indeed jump as high as you can onto a box, and you might repeat that a couple of times. Okay, and you might do a jump onto a box or with distance with maybe a weighted vest or something like that. Don't worry too much about the power stuff. Nothing other than it's just that we need to know. It's not a bad thing. It just means that your knowledge isn't there, Mo. Okay, so it's, you know, you might get marked down a little bit because we can't help but mark you down a little bit. But not to worry. We're not trying to catch you out. We're just trying to see how much you know. Hope that answers your question there, Mo. Okay, the big point where people can fail is safety. So we've got to think about exercise contraindications. Okay, exercise contraindications, people who should not be exercising at all and would be inappropriate for exercise. Yeah, it'd be dangerous to get them out of bed and doing stuff. Okay, unless they've been cleared by a physician, okay, or someone that knows what they're doing in order to get them exercising again. So in case of cardiac rehab, most of our patients will be cleared by the cardiologist in order to go to cardiac rehab in the first place. But we've got to make sure that that person that we're about to mobilize or do exercises with hasn't got, for example, a DVT, a deep vein thrombosis or something like that. Okay, so we've got to be careful and think about contraindications for exercise. Contraindication exercises have been covered multiple times, Holly, throughout. Okay, so you need to just, if you go to the ebooks, okay, go to the ebooks, guys, and they've got all your answers. You obviously haven't looked at my ebooks. Do you know how long they took me to do? Okay, a long time. I do that for your benefit. Make sure. Okay, right. I'll forgive you then, Holly. Right, so we've got to then think about the exercise. No, it's not an audio book, it's an ebook. Okay, I can do an audio book, but that'll be for next year now. So we're going to do exercise precautions as well. So exercise precautions are things like, have they eaten a big meal? Okay, are they wearing the right right clothing and the right footwear? Okay, are they hydrated with water? You know, have they been drinking alcohol that day, for example? So it wasn't uncommon for people to come to cardiac rehab and they'd had a drink at lunchtime, for example. Obviously, it was inappropriate for them to exercise because they'd ingested alcohol, and exercise and alcohol do not mix. Got to make sure that they've completed a physical activity readiness questionnaire. This is more for the group exercise than anything else. And then we've also got to think about the equipment that we use with our patients and any safety issues. Is the environment clear? Using the ELITE acronym and using chairs maybe for safety, either helping with balance or something where we don't want our patients falling over. And remember, our patients will be really anxious and nervous in those early stages of rehabilitation. So safety, 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 really important. You can fail if you don't get the safety. So revise those contraindications and those precautions. So here I've combined a few of them. Okay, so what I want you to do is tell me if it's a contraindication or a precaution. Okay, so avoid exercise for 2 hours after a big meal. Is that a precaution or a contraindication? It's a precaution. Yeah, good. Do not exercise if you have a fever or viral infection accompanied with muscle aches. Precaution or contraindication? Yeah, absolute contraindication. Okay, particularly in this environment. Okay, do not exercise if your systolic blood pressure is greater than 200 or your diastolic blood pressure is greater than 100. It's an absolute contraindication. Do not exercise if your heart rate is above 120 beats per minute. Contraindication or a precaution? It's a contraindication. Okay, absolute contraindication. If your resting pulse is over 120 beats per minute at rest and you've been doing nothing, there's something very wrong. Okay, if you have a hot swollen joint, a hot warm swollen joint that is painful, precaution, contraindication? Yep, it's a contraindication. Okay, because they might have a DVT or something like that. Okay, if you have osteoporosis, is that, it does depend, David, it does depend. Okay, if you have osteoporosis, is that a precaution or a contraindication? Yeah, it's what we call, what falls into what we call a relative contraindication. So if you've got diabetes or osteoporosis, we need to be aware that you have the disease pathology, but you're still able to exercise. So this is where it falls in the middle between, it's not an absolute contraindication, it's not a precaution, it's a relative contraindication. Okay, so give me a thumbs up in the chat if you're happy with absolute contraindications, relative contraindications, and precautions. Yeah, because it's that. Thumbs up, yeah, okay. And obviously, we're going to make sure they stop exercising if they experience any joint pain or discomfort or chest pain or anything like that. So we just got to think about those important things. Okay, so here is the PAR-Q, the wonderful PAR-Q. Who can type one of the questions from the PAR-Q in the chat for me? Anything you like. One question from the PAR-Q. Do you get chest pains? Yes, Alex P. Done. Stroke? Yes, Hannah. Dizziness? Yes, David. Then name. Magali, come on, you can do better than that. Heart conditions. Okay, I don't think you're taking this seriously. Okay, lightheadedness or fainting? Yes, Megan. Any medical conditions? Yes, Alex P. Muscle or joint problems? Yes, James. Well done, guys. This is brilliant. Okay, you clearly know these. Okay, how often you exercise is more of a subjective history, Bethan, than what we're after there. Okay, so that's not on the PAR-Q. Okay, so what do we need to think about in terms of safety when we prescribe exercise to patients, guys? What do we need to think about in terms of safety? The environment, yes, James. What else do we need to think about? Equipment, yes. Yeah, previous medical history, yeah. Are they wearing appropriate shoes? Yes, James. Okay, can they do things unsupervised? Yes, Lauren, good. I like that. Good. Anything else? Cognitive ability, yes, David, excellent. Yes, Will, can they actually do the exercise? Have you got them to execute and adjust the exercises? Okay, we seem like we're all on the same page there. Well done. Okay, so when we think about needs analysis, we're going to think about what is the impairment status of that person at that particular period of time. Okay, because impairment status will change as the patient goes on their journey. Which components of fitness do we need to address? Is it early stage range of movement, balance and strength, or is it late stage power and agility and speed? Okay, we've also got to think about their age and their previous exercise experience. Okay, we've also got to think about the 4 P's of functional movement. Who can type in the chat the 4 P's of functional movement? What are the 4 P's, guys? Okay, it's not planned. That's posture's one of them. Okay, James is there. Look, purpose, posture. Yeah. Okay, you got to be quick, guys. Alex P's there, Megan's there, but James D, you were there first. Okay, if anyone, Magali, you're saying planned. Okay, that's the wrong one. Okay, so that's reps. Okay, so give me, so you remember the acronym REPS, REPPS. Okay, that's to differentiate exercise from physical activity. Who can remember the acronym REPS? What does REPS stand for? R small e PPS. Exercise is repeated. Yes. Plan. Yeah, Rebecca's there. Well done. Okay, it is repetitive, planned, purposeful, and structured. And Lauren's there. Hannah's there. Okay, although some dodgy typing there, Hannah. Okay, then we've got to think about what pattern of movement and what level of movement. Are we talking about level 1 functional movements or level 2 functional movements? No, Kate, that is for you. I've got the ebooks. The ebooks, Kate. Okay, you want to play, don't you? Okay, I've done these ebooks for you. Okay, I've worked so hard on these ebooks. I'm beginning to think, just tell me you read the ebooks. James, don't ask where they are. They're right at the start of PET. Go to the PET module and it says ebooks. Okay, it's too late, Alex. It's too late. Don't wind me up, Kate. Don't wind me up. Okay, so we're going to move on. These are the 4 P's of functional movement: the purpose, the task orientation, the posture, where do the joints need to be in terms of hip flexion, knee flexion, ankle flexion, what position do they need to be, sitting, standing, lying, and what pattern of movement. Normally the pattern of movement refers to a level 1 functional movement. Okay, so there are level 1 functional movements. We've got squat, lunge, push, pull, twist, and of course twist, resist. Then we've got hinging or bending, and then we've got gait. Okay, so there are level 1 functional movements. Okay, they're all in the ebook, Kate. They're all in the ebook. Okay, outcome measures. We're going to move on to outcome measures now. So I'm going to 100% ask you about outcome measures in the Viva. So you need to revise this, guys, and this isn't normally done very well. So I'm hoping your year will be different. So if you're not assessing, you're guessing. That's why we use outcome measures. Outcome measures need to be valid and they need to be reliable. They need to be sensitive to change. They need to be clinically feasible. They need to be easy to use. Okay, there's so many things that outcome measures need to be. They need to be standardized. We could talk about outcome measures all day. However, I just want you to have a basic theme about outcome measures, because this is what will come up. You've got to get the right outcome measure. So, for example, if you give me a knee to wall outcome measure and you call that strength or coordination or something other than flexibility, then you are wrong. Yeah? If you give me a 1 repetition max, which is an outcome measure for strength, and you say it's endurance, then you are wrong. Okay, you've picked the wrong outcome measure. And here's where you can get caught out. So just revise those outcome measures. Very important. Okay, so things like range of movement with the goniometer. Okay, isometric muscle strength. Remember, we're doing isometric muscle strength, not power. Power will be assessed by jumping, for example. Local muscle endurance, single leg step down test, single leg calf raise. Balance and proprioception, we've got Y balance or standing reach. Okay, and then functional ability, that might be a task specific one, like being able to jump and head a ball, for example. And remember, it's an outcome measure is about creating a baseline of which we can measure improvement from. Okay, so we have to establish a baseline before we can know where we're going, and that way we can see we can progress or regress accordingly. I use this example all the time, but if a patient comes back to me, say they're an Achilles patient, and they come to me and I give them some single leg calf raises to do as their homework, and I come back in and I reassess them. If they have not improved, i.e. they've not been doing their exercises, we have a conversation about behavioral change. If they have improved, we can have a conversation about exercise progression. Just give me a thumbs up in the chat if you understand that, guys. Yeah, about the different, about why we use outcome measures to do that. Great. So you can use the different components of fitness accordingly. Behavioral change, massively important. So remember, there's two types of outcome measure. There's patient reported outcome measures. These are questionnaires. Yeah. Okay. So where the patient sort of asks something as well. So we try to make the subjective objective. Okay. So sometimes we have a line and we say, mark an X where you think your pain is. Yeah. And then we measure that, and then we turn the subjective into something objective, because we can measure pain along the line. With a numerical rating scale, we can take something subjective like pain and make it objective by giving it a number. Say, oh yeah, I've got 5 out of 10 pain at the moment. And then you do some treatment, do some exercise therapy, and then they might report their pain is only 3 out of 10. Okay? But then what we're after with objective outcome measures, we're after a component of fitness that we're measuring. Yeah, but both outcome measures are valid. So if we're doing the rate of perceived exertion, if you get the cardiac rehab question, this is really, really important. The rate of perceived exertion is normally between 0 and 10. The Borg scale is between 6 and 20. Don't ask me why it's between 6 and 20. It just is. And we want to be working where on the Borg scale. If we're working on the Borg scale here, where do we want to be working in cardiac rehab? Yeah, is there already. Okay, James is there already. Holly's there. Grace is there. Brilliant. Okay, well done. Okay, and what we do is we actually go round in the session, and we'd be like, how hard do you think you're working? And the patient just subjectively reports it. Yeah, and then we measure that they're working at the right tempo based on their subjective opinion. Yeah, again, one of those things, I think initially, David, it was based off of 220 minus their age. However, the research for this is so old now. I'm not sure if it's relevant. And he's talking about the modified Borg being 1 to 10, which might be much better. However, in the literature and on the exam, we're using the old Borg scale and the modified Borg scale. So it doesn't really matter which one you use. Does that make sense, guys? As long as you understand there's 2 different scales and you know roughly where someone's working. Just give me a thumbs up if you're happy with that answer, guys. Good. Okay. Right, quick questions back for you guys. Okay, what is an outcome measure? Type it in the chat. What is an outcome measure? Yes, Rebecca, great answer. Yes, Jay, that's good. Yes, David. Yes, Kate. Yes, Hannah. Okay. Yeah, Magalie's actually giving me a sensible answer. Okay, today it is a baseline. Okay, for you to measure your improvement, hopefully your improvement, or certainly your progress anyway. So why do we use outcome measures? Why do we use outcome measures? Evidence-based practice. Yes, Rebecca. Rebecca, your typing is super fast. Yeah, okay. Why else do we use outcome measures? There you go. Grace has it. You're not assessing, you're guessing. David has it. Okay, yeah. If you can sneak that into the exam, I will give you an extra mark, guaranteed. Okay, and what do outcome measures need to be? What do outcome measures need to be? Type it in the chat. Yeah, Mary. Excellent. Yes, Mo. Yeah. Yes, Rebecca. Yes, Holly. Yes, Megan. Okay. Standardized. Yes, Rebecca. Easy to use. Yes, Mo. Okay, fantastic. Good stuff, guys. Looks like we're all on the same page. So the practical side of the exam, what I want you doing is I want you explaining why you are doing the exercise. Yeah, tell the person the purpose of the exercises. This is going to benefit you how? Yeah, and then use the idea, introduce, demonstrate, execute, and adjust. Try giving some hands-on. You are hands-on therapists. Do some hands-on therapy. Set the patient in the right posture. I use hands-on therapy all the time, particularly when I'm adjusting movement. I think it's very important. The patient wants to know that they're in the right posture in terms of their joint positions. Okay, so you remember the 5 pillars of stability? Okay, where is the neck? Where's the C-spine? Where's the scapular position? Have we got tone in the midline? Are they in the center? Okay, or are they shifted over to one side? Is there a bit of tone in the glutes? Is the pelvis in the right position? What's the foot position doing? So they're the things that we look at when we talk about the 5 pillars of stability. Give me a thumbs up in the chat if you're looking at the 5 pillars of stability. Okay, yeah. Massively important when we do this. And then we've got to think about progression and regression. We've got to think about the feedback. So if we look at why do we use the IDEA acronym? We introduce the exercise. That means that the patient can use their auditory learning style, okay, and their analytical learning style. Then we demonstrate. That way the patient can use their visual learning style. Okay, then they execute the movement, which means that they have that kinesthetic learning. Okay, and then what we do is we adjust them so we have kinesthetic learning. Okay, and putting them in the right position. That's why we use the acronym IDEA. Okay, because we hit all 4 learning styles with that. We hit the analytical learning style. Okay, when we're moving. Just give me a thumbs up in the chat if we're now happy with why we use the acronym IDEA. So it corresponds with all 4 learning styles. Quick thumbs up in the chat if you're happy with that, guys. Yeah. Okay. So yeah, someone's asked me. So we've got the visual learning style. Yeah. I see, I do through mirror neurons. Okay. I hear, I understand. Okay. Or what happens is I hear, I see, I do, and then I analytically understand. Does that make sense? So when we analytically understand it, we've heard it, we've seen it, we've done it, and then we process that. And that's to do with skill acquisition. Yeah. So Knapp 1984 defines skill as the learned ability to bring about predetermined results with maximum certainty, often with minimum outlay of time or energy or both. Okay, so skilled movement. Okay, here we are, a quick revision. So you'll be doing this with Cedric or Justin next week. So make sure you prepare. All the questions are there in that practical folder. If you can't find them, just type in the send me an email and I'll show you exactly where they are, but they're on Blackboard. go to the PET VIVA Practice Practical drop-down menu. Cedric, Justin, and the questions will be there, so there's no excuses not to prepare. Yep, that's the format you'll be using. That will take roughly an hour and 10 minutes to get through that. That's it. Well, the one with so there's 3 questions for each case study, Grace. Yeah. Okay, so there's 3 question sets for Justin, 3 question sets for Cedric. Okay, and you don't know which question set you're going to get because the person that's going to examine you is going to choose. Yeah, you're going to have to do there should be 3 question sets rather than 2, Holly. Okay, so it gives you examples of all 3 types of questions that you might get in the exam. That's why you revise for all 3 question sets. Give me a yes in the chat if you understand that. 3 question sets for Justin, 3 question sets for Cedric. You're going to revise either Justin or Cedric. Okay, you don't know which question set you're going to get. Yeah, otherwise, where would be the fun in that? Okay, so remember, we can include anything from that with the exception of hydrotherapy. We've had to take hydrotherapy out. We've also taken out good posture and good movement. I have to correct that. Okay, so hydrotherapy will not be asked in the exam. Okay, so we come to the end of our hour of power, the end of the last taught PET session. There's no Kahoot this time because I want you to focus your time on doing the CAA practice. You've only got till tomorrow. I know, Kate. What you could do, Kate, is you could read one of my ebooks instead. Yeah. Okay. So remember, yeah, good. Well, it's you know, the key to a good lecturer is always leave your audience wanting more, Megan. Yeah. Always leave your audience wanting more. Okay, so we've done the PET principles. We understand how to implement them to exercise therapy. Okay, and we are ready for our Viva practice session. And all I can do now is say that we will have we will have a revision session before the exam. Any questions? Please, 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 just email me. I will get back to you as soon as I can. I appreciate the fact that I am doing other things. Have a quick go at the CAA. The CAA disappears. Let's have a look. Disappears tomorrow. Okay, your last chance to do the CAA practice is tomorrow. So I wish you good luck for the CAA next Thursday at 2 o'clock. Next Thursday at 2 o'clock is the CAA, and you can do that in the privacy of your own home. I'm not sure, Kate. I think you should do. It will certainly tell you the answers to the practice CAA. Okay, and it's 45 minutes, so leave an hour. Leave it an hour. You want me to go back one, James? Yeah. No, David, like the real CAA will be a bit harder than the practice one. The real CAA is a little, I've made it a bit tougher than the other one. So expect it to be slightly more challenging because I've got to cover lots of breadth of knowledge there and I've had to adjust it. You just wanted the picture? That one? Did you want that one? Okay, you know these slides are available on Blackboard, as is everything, guys. Okay, sometimes I think you don't go on Blackboard enough, you know. Sometimes I don't think you listen to my podcasts or you read my ebooks. That's what I'm thinking. But it doesn't matter because it's the last PET session now. Okay, so all I can say, guys, after we conclude the hour of power, it's been I'm gonna tell you soon. I'm gonna tell you soon. Okay, there's far too much banter in this. You are far too familiar with me now. Okay, they're far too familiar now. Okay, all I can say is it's been an absolute pleasure teaching you this academic year. It's been really challenging, and not just myself, but all the PET team, all the lecturers here. We're immensely proud of how hard you've worked. in these really, really challenging circumstances. So be proud of yourself. Okay, the lecturers are all very proud of you. All we want you to do now is show us how good you are in the exam. And remember, an exam is just a test of what you know. I hope you find that helpful. No, it's just challenging teaching you, Kate, because you've not been looking at my ebooks. Okay. So all we need to do now is say thanks ever so much, guys. Please email me if you have any questions. It's been emotional. Okay. I've thoroughly enjoyed it. Any questions, let me know. Read the ebooks. I will put this study this been recorded. I'm going to stop it now.